in scientific leadership, health policy, as well as training. She's been very instrumental in translating research findings in the field of PMTCT into policy, enabling Kenya to be one of the most successful national PMTCT programs in sub-Saharan Africa. The Kenyan program is known for being responsive to evidence, and this has resulted in a significant reduction in the rate of mother-to-child transmission between 2003 and 2019. Professor Ruth Ndwati has led multiple clinical trials, including initial studies that looked at the transmission of HIV through breast milk, and later KNH-UoN study. She was lead at the Kenyan site, which evaluated triple therapy for PMTCT. The findings of the KNH-UoN directly informed international PMTCT guidelines and resulted in more efficacious PMTCT regimens. At the University of Nairobi MEPI program, Professor Ruth Ndwati was responsible for the decentralized research, which supported over 400 undergraduate students in medicine, nursing, pharmacy, and dentistry to undertake short-term clinical exposures in 18 non-tertiary sites across Kenya. The students received mentorship by local specialists and participated in micro projects that addressed priority areas of the respective facilities. Recently, Professor Ruth Ndwati and her colleague competitively won an award, HEPI, whose aim is to create a pipeline for training physician and clinical scientists. So welcome, Professor Ruth Ndwati, and take us through the neuroscience behind risk-taking behavior of adolescents. Karibu.
Thank you very much. So let me start off by sharing my screen. Let's see. Let's see. Can you see my screen?
Yes, we can see it.
Okay. So I've been asked to talk about the neuroscience behind risk-taking. And when I thought through, actually, my interpretation of this is that we just need to review development, and particularly cognitive development during adolescence. And this is what I have prepared for us this afternoon. Let's see. So broadly, that is the outline of my talk. So who is an adolescent? An adolescent is this person who's aged 10 to 20 years and beyond, actually. It is an important stage of development that marks the transition from childhood to adulthood. And you have both physical, sexual, cognitive, and emotional changes that have an impact on the which have an impact even on the success of our ARV treatment for HIV-infected adolescents, let alone just a success for the adolescent as it transitions into adulthood. So we classify adolescents in different ways. And we use different terminologies to refer to this stage of life. World Health Organization classifies adolescents as 10 to 19 years, and those who are aged 10 to 24 years are called young adults. Reproductive health often classifies the 15 to 24-year-olds together as adolescents and young people, and there's a particular focus on adolescents and young women in HIV programming, and in fact in reproductive health programming. Now, there's a broader term that encompasses young people, the term young people, which encompasses young people aged 15 to 35 years, And often there are social benefits targeted to this population to support their individual and national human capital. For example, you can get access to a youth fund to start your business. There are many scholarships for higher education overseas that have a cutoff point of 35 years. Finally, the classification of women of childbearing years, a cohort that is a target for the Demographic Health Service, which groups adolescents and young women and older women into one cohort. Now, there's a growing body of knowledge that adolescents are, first of all, not the same as young women and older women, and that even within the bracket of adolescents, there are differences based on age, and the interventions that work for adult women do not necessarily work for adolescents. And even within those, the adolescent, this variation of what possibly will work. You will see this. I hope this will emerge as we continue with this discussion. Now, adolescent health lays the foundation for lifelong health. It also lays the foundation for economic productivity and well-being, and impacts on early life development of the next generation. Adolescent sexual activity, particularly early sexual debut, is associated with pregnancy, STDs, poor academic performance, and higher likelihood of manifesting symptoms of depression for both girls and boys. A recent study in Kenya demonstrated that sexual debut before 15 years of age was not only associated with that, was actually associated with that trajectory of high-risk behavior, but also significantly increased risk of intimate partner violence. Now, the risky behavior, substance use, and physical inactivity in adolescents carry on into adulthood and correlate with increased morbidity and premature mortality. Now, several countrywide data sets, in fact, from the developed world, have clearly demonstrated that abstinence during adolescence is associated with increased transition from secondary school into college education and ensuring success in human capital development. Let's see. Now, this next slide is an analysis, sorry, went quickly. It's an analysis carried out by a community focus group discussion in a rural African village, actually here in Kenya, on consequences of early sexual debut and highlights the lived experiences. And as you can see, this, I think some of these things must have been discussed yesterday by the speakers who introduced the topic of adolescent health. Now, adolescents, there are a lot of births among adolescents, many unintended pregnancies, and many complications of childbirth in adolescents. In fact, the maternal mortality among adolescents is higher than in adult women. And there are also many abortions, but Kenyan data shows that right now abortions are more common in older women, actually the age group over 25 years. But the abortions certainly contribute to maternal mortality. In addition, adolescent mothers, young women aged 10 to 19 face high risks of eclampsia, pupillometritis, systemic infections compared to older women, and their babies tend to have more low birth weight infants, preterm delivery, and severe neonatal outcomes. So it is not they're not good outcomes for these young girls. Now, just to illustrate, based on our Kenyan data, we have high teenage pregnancy rates among 10 to 19 years that were particularly reported this in this COVID times. This is data from 2019. And where you had the highest teenage pregnancies, you also had high incidence of HIV. But what's I think striking is that HIV prevalence was 2.5% among women who had sexual debut before the age of 15 years, compared to 4.7 among those who had sex after 25 years of age. So very illustrating the very significant differences in risk associated with this early sexual activity among adolescents. Now, what are the tasks for the adolescent? As I said, adolescent is a transition from childhood to adulthood. It is characterized by these changes in physical, psychological, and emotional functioning. The key developmental tasks are the structural changes of physical growth and sexual maturation. And then there are the psychological tasks of emotional development and cognitive development. In addition to these changes, as these changes take place, the adolescent is interacting with parents, and that space is changing. They are interacting with society. Their peers are increasingly important. They're having to find out who they are, who am I, and they also are making career choices. The environment in which the adolescents lives and the community norms also greatly impact the development of the adolescent. Now, the human brain is central to adolescent development. The brain makes hormones that influence physical growth and sexual maturation. We use our brain to think, reason, feel, express emotions, communicate, make decisions, formulate values, and create relationships. Now, essentially, the teen brain is under construction. Compared to the adult brain, the teen brain has greater capacity to learn and create. It has increased risk of damage from drugs and alcohol, and it has increased risk of developing addiction compared to an adult. There's also increased risk of mental illness. There's this increased desire for risk-taking, and the parts of the brain that control emotions are not yet mature, and we'll see a bit more of this. The adolescent development is classified, it's divided into 3 stages. There's early adolescence, which is 10 to 13 years, mid-adolescence, 14 to 16 years, and late adolescence, 17 years and older. Girls may reach adolescence as early as 8 years, and boys may be delayed up to 12 years before they have signs of adolescence. In a recent survey, national survey, yet to be published, about 13% of adolescents have not yet achieved pubertal changes by the age of 18 years. Now, each stage is characterized by a set of biological, psychological, and social issues, and the development is sequential. If we now look at the different stages of development, we start off by talking about physical development and sexual maturation, and I'm cognizant of the fact that most of you know this stuff, but I think it's important to review it so that we understand our adolescents. The triggers of onset of puberty are not fully understood. There are hormonal changes predating the visible features of puberty that start as early as 6 years of age, and which may manifest with the development of underarm odor and fine pubic hair. This is under the influence of androgens produced by the adrenal gland. Then during middle childhood, there's gradual increase in luteinizing hormone. And then puberty changes begin when there's a dramatic increase in the sensitivity of the pituitary gland to the gonadotrophin-releasing hormone. And there's pulsatile release of this gonadotrophin, GnRH, luteinizing hormone, and FSH during sleep, and it corresponds to increase in gonadoandrogens and estrogens. As I've said, the pubertal development in girls precedes the boys. And in this early adolescence, 10 to 13 years, girls experience peak growth velocity. At this stage, the girls may be bigger than the boys, and in co-educational facilities, the boys may be the target of harassment by the girls. And this, I think, the teachers report. During this stage also, the adolescent starts to develop increased interest in sexual matters. At this stage, the main thing is that there's anxiety over the emerging body changes. I think the other important thing is at the end of this stage, both boys and girls are capable of procreating, becoming moms and dads. And we have seen it when we talk about young children who present with pregnancy in our facilities. Now, the mid-adolescent is characterized by further maturation of secondary sexual characteristics. The boys go through their peak growth velocity, and by late adolescence, and the girls achieve menarche in mid-adolescence. And so you can see the disconnect that the adolescent girl is capable of conception even before the period menstrual periods arrive. Okay. Now the stage of physical development, the stage of physical development links in with the risks of sexually transmitted infections, and it's especially HIV. Now, girls who achieve sexual debut before menarche, as I said, may never know what is normal vaginal health, what is normal vaginal secretions. In our HIV studies, we observed many young women with abnormal vaginal discharge who did not realize this was abnormal. When asked whether they had any abnormal discharge, they would report they were all right, but on examination found to have profuse abnormal discharge pointing towards the presence of sexually transmitted infections. The genital tract in adolescence is not mature, and as highlighted in this slide, there are all these factors that increase the risk of HIV infection or even infection with STDs if they're foreign sexual encounters. Now, in food insecure populations, adolescents who are going through the stage of high growth velocity may actually experience acute malnutrition. One of our residents recently was looking at nutrition of school-age children all the way to 14 years and actually observed increased prevalence of malnutrition among the 10 to 14-year-olds. So they are old enough to be asked to take less food when there's a shortage, but then they are growing rapidly and they are then not able to meet the demands for their body. Now, the human brain grows starts from fetal life and goes on until attaining adulthood. And there are several theories, and this slide shows there is a MRI studies out of a large study done actually at Stanford University, and shows the change that there's actually physical change of in the brain as it matures. And the more blue it is, the more mature the brain is. There are several theories on how the brain develops, especially in the development of human thought. One school of thought is that there's a shift from concrete thinking to formal operational thought as a result of increased knowledge, experience, and cognitive efficiency. The other school of thought is that there's a qualitative reorganization of the thinking process, and there's data to support this. Throughout childhood, there's an increase in cognitive processing, largely attributed to the increased myelination of neurons and pruning of less used pathways. And this process is actually greatly increased during adolescence. So the 10-year-old has more neurons than the 18-year-old because they've gone through a process of pruning. But the myelination of the 10-year-old is less compared to the one of the 18-year-old. There's also a lack of clarity of whether the hormonal changes that are taking place also influence cognitive development. So this is a hot area in terms of research. Now, during adolescence particularly, there is development of the dorsolateral prefrontal cortex and superior temporal gyrus. These are the areas of higher order association, and they include the ability to inhibit impulses, the ability to weigh consequences of decisions, ability to prioritize, and ability to strategize. This area is the last to develop, and usually is fully developed in the 20s. And so, in essence, as I'll show in a subsequent slide, during adolescence, this higher order of thinking that is controlled for by the maturation of the prefrontal cortex has not fully kicked in. Now, to focus a little bit on the cognitive development, we go through big changes in how we think, right from childhood. And the early adolescence is still the early adolescent is still thinking very much like the school-age child, where there's magical thinking and egocentrism. The 14 to 17-year-old now has increased increasing change in the way that they think, but they have what we call concrete operational thought. And then finally, as they go into their 20s, you develop what is formal logical thinking. The formal logical thinking is where you're able to hold abstract thought. And because you've developed this, you have the ability to manipulate algebraic expressions. You are able to reason from known principles. You're able to weigh many points of view. You're even able to think about the process of thinking. Now, young people are able to apply operational thought to schoolwork, but not to personal dilemmas. When they are under stress, they regress to more concrete operational and magical thinking. And I think this is something to really ponder on as we work with adolescents, vulnerable adolescents, and who are programming very often focuses on the adolescents as opposed to the adolescent parent dyad. So in early adolescence, to sort of summarize our cognitive development, the adolescent still has concrete thinking. They have little ability to anticipate long-term consequences of their action, and they literally interpret ideas. In mid-adolescence, they are able to conceptualize abstract ideas such as love, justice, truth, spirituality. They question more. That's when your child is always asking questions. You tell them to do this, they always ask why, they always have another answer. And they may they may also perceive future implications, but they are not able to apply this thinking to decision making around their own personal issues. And the late adolescence is when we get this form of operational thought. We develop a future-oriented approach with a sense of perspective. There's a lot of idealism at this point. There's an ability to understand and set limits. And you also now have gained an understanding of other people's thoughts and feelings. What about emotional development? In early adolescence, there are wide mood swings, intense feelings, and very low impulse control. As they move into mid-adolescence, they swing into this sense of invulnerability and risk-taking behavior peaks. The adolescent experiences increased intensity of emotions, and there's an inclination to seek experiences that create high intensity emotions, and this drives this risk-taking behavior. And it's only then in late adolescence that they start feeling sense of responsibility. They realize that they are vulnerable. They are able to think of others. They are able to suppress one's needs, and they have less risk-taking. In the context of reproductive health, you find that the adolescent who is 18 years and older is more likely, they're more likely to use, say, for example, protection before, even on their first at sexual debut, compared to an adolescent who's aged less than 15 years. They're more likely to have less risky behavior compared to a younger adolescent. The other area that emerges is the whole area of self-concept. And I hope you can identify with these pictures. Eh? You know, as a young adolescent, people are preoccupied with changing body, self-conscious about appearance and attractiveness. There are issues of fantasy and present, and very focused on just the present. You may remember the many hours you spent in front of a mirror, looking at that one pimple that has shown up, you know, or you have children who are doing that. Then you go on to read adolescence, where again, one is now concerned not just with the body shape, but are you attractive? And there's increasing introspection. And really, this is the classic adolescent. And then, of course, by later adolescence, you have more stable body image. Of course, adolescents, even though the adolescents are still concerned about how attractive they are, but they're much more independent and have a firmer identity. And I think these pictures illustrate also the differences between the girls and boys, and you find that the young men are the development is slightly later. Hence, you can see these two are probably at the same stage of development, but of different ages. Eh? Yeah. And then there's the issue of moral development, and this rides along cognitive. It parallels the cognitive development. In early adolescence, the adolescent views the relationship with adults in terms of power and fear of punishment. So an adolescent at this stage can be intimidated into all sorts of activities by an adult, and making them very vulnerable actually to sexual exploitation. They have a clear perception of what is right and wrong, and they're very absolute and questioning, and questioning about those absolutes. As they go into mid-adolescence, and this is now the kids who are going into secondary school, they feel strongly that, you remember their increased sense of justice. They feel that punishments must be fair, and otherwise, if it is unfair, they will complain. They may even rebel, and this rebellion may take all sorts of forms. It may be rebelling at home. It may be in school. And then, of course, once they reach adulthood, they have a better balance of their values, and they reflect the morals and values of the society they're growing in. Now, what about relationship to family? This is the other big area of change, but also does affect the adolescents as they grow. Right from the time you're born, there's a growing separation from your mother. You move from being in a fetus, in utero, you're born, you are breastfeeding. By 9 months, you start realizing, I am different from my mother. You can even refuse to feed. Then you learn how to walk. And the 3-year-old is able to go away a few steps from the mother, come back, and just gradually separation to and independence towards adulthood. Now, early adolescence is a big stage. They feel the growing separation, estrangement from the family. They express the need for privacy. They don't want. I give the example that I don't want my mother to walk into my room without knocking. Those are for the children who have the opportunity to have their own room and somebody can knock. But even for children who poor children who live in the sheltered space, there's still that little space that they consider theirs and which should not be interfered with. they may have where they put their clothes, they may be very untidy, but they don't want anybody to touch it. Eh? Then as they go into mid-adolescence, you start running into conflict with parents. They feel that the parents don't understand them, and they feel that their views are not valued. The adolescent is going through a stage where they are questioning the parental values, and they declare they are different from their parents. Now, if the parents don't understand that this is a stage of development, and the adolescent is feeling strongly about issues, you end up with a lot of conflict. And I think constantly you hear parents talking about the terrible adolescence. Eh? And then, of course, they've gone they go through that stage and reach adulthood. And really, they now, when you hear your child saying, "Can I get advice from you?" They've really navigated that space, and they are an adult, and they recognize that that you as a parent can advise them, you can give them good value information, and you can work together as a team. But that the mid-adolescence it can be very untidy for families. Then there's the relationship to peers, and early adolescents seek the relationship of the same sex relationships, usually to counter the feelings of instability. They are growing, they don't understand their body, so they sort of hang together. So the girls play with girls and the boys with boys. And you can remember this stage is primary school. The boys are saying the girls have fleas, the boys have fleas. We all remember that stage. Then as they go on to mid-adolescence, their peers become very important. It is intense. They have intense relationship. There's preoccupation with peer culture, and the peers provide behavioral example. And I know this is an area where people have tried to use peer counselors and peer groups to modulate behavior. And then, of course, you go into late adolescence where your peers are no longer so important, and the values of the peers are not so important, and you are functioning as an individual. Now, we need to be careful about what our society nurtures as peer culture or peer values, because that in itself may be what will recruit others into activities that maybe are desirable, but may also recruit them into what is a desirable activity, and which will help them to transition into adulthood to be able to achieve their the goals of achieving their human capital, their full potential as people. Now, when I was asked to talk on this issue of development and neurodevelopment and the adolescents, the newer texts actually have drawn out sexuality as a stage of and look at it in the different stages of development. And early adolescence is described as adolescents having increased interest in sexual anatomy. They're wondering about these changes. They have anxiety and questions regarding their genital changes, and there may be some limited dating and intimacy. And we see it from our own data, case data, Kenfia, etc. Then into mid-adolescence is a stage of testing whether you are attractive, testing whether you are able to make relationships. And this testing, the results in serial monogamous relationships, typically very short. And at the same time, there's a consolidation of one's sexual identity. Now, what culture, teen culture we have around the management of these relationships will determine the level of risk our adolescents have. Right now, when we interview adolescents, when they tell you they're having a girlfriend, what they're telling you is that they are engaging in sexual intimacy. I don't know. I don't know whether I think we have failed to teach how to have friendships, safe friendships, because I think those sexual intimacy in the mid-adolescence is not safe, because your brain is telling you I like you today, but then in a few months of time, you've lost interest in that person and you're into another relationship. You're also at the stage where your brain you cannot conceive how your actions of today will relate to your outcomes tomorrow. So I think food for thought for us on how to approach these adolescents. So I say that to briefly summarize these issues of adolescent development is that you have on the one side the hardware, that is you have physical sexual development. Your emotional development is such that in mid-adolescence, in physical and sexual development in early adolescence, then you have invincibility and risk-taking in mid-adolescence, and cognitive maturation in late adolescence. The behavior that is associated with those changes are the sexual desires and urge to experiment. In mid-adolescence, the risk-taking and serial monogamous relationships, and then in adulthood, your long-term relationships. If one considers the physical growth and sexual maturation as hardware, and emotional thinking as the software, and the cognitive development as the antivirus, to use the language of today, the challenge facing adolescents globally and here in Kenya is that the hardware is fully functional before the software and antivirus are fully installed. That is, I think, the problem that we are facing. Now, let me take a few minutes to just very quickly talk. Am I over time, Dr.
Yes, Prof. 15 minutes over time.
Can I be allowed just a few minutes, and I'll go very quickly now?
Okay, kindly.
Yes. Just to talk a little bit about the relationship of the adolescent and the family, because I think it is central. WHO, as far back as 1997, identified that home as a first intervention setting and family as key players for the delivery of this intervention. And they highlight how the family is central to the health of the adolescent. They provide support, love, promote moral development and sense of responsibility. And they provide role models. They set expectations, they negotiate for services and opportunities, and filter out, counteract harmful, inconsistent influences. Now, the problem is that most parents and community members are not aware of the emotional and cognitive development and simply assume their children are indisciplined, leading to a lot of conflict. On the other hand, adolescents would like to hear these stories from their parents, and this has been a consistent finding in research. The next thing is that there are clearly 5 roles that parents need in nurturing adolescents. There's the role of loving your child. There's the one of behavioral control. There's respect for the individual. There's modeling appropriate behavior, and there's the provision and protection. And I'll show how these relate to the risks that we are dealing with the adolescents. So a well-connected adolescent perceives themselves to be accepted by their primary caregivers. Those adolescents who are poorly connected are those who see themselves to be rejected by their primary caregivers, or who are experiencing psychologically harmful and hurtful behavior. For example, your parent may be emotionally cold and affectionate. They may be outright hostile and aggressive, or they may just be completely indifferent and neglect you completely. Now, the adolescent who is well connected is less likely to consider or attempt suicide, is less likely to be involved in interpersonal violence, is less likely to start smoking, less likely to use alcohol, and less likely to have sexual intercourse at a young age. Now, then there's the issue of monitoring behavior. And This encompasses parents' actions aimed at shaping or restricting adolescent behavior. You remember we said that adolescents don't always have an idea of how today's actions are harming them tomorrow. So it's important that the parent plays that role. So the parent should supervise and monitor. Please know where your adolescent is. You should establish boundaries, about behavior and the consequences of that misbehavior. And you should convey clear expectations of behavior. When you do this, then your adolescent is less likely to take risks of will decrease risk of drug and alcohol use. There's decreased sexual activity. They will have later age at first pregnancy. There's reduced risk of depression, reduced school problems, reduced issues of victimization and delinquency. There's decreased negative peer influences. Actually, what we're saying is that adolescents want you as parents to have rules and regulations and to enforce them, but in a clear, loving manner. Then there's also the need to respect the individual. Okay. And when you respect the adolescents who perceive their parents to be psychologically over-controlling and disrespectful have higher levels of internalized problems, such as depression and eating disorders, but also the external ones like risky sexual behavior and substance use, okay? So you need to respect the adolescents, see that their opinion is important, listen, even when their rationalization is not so, reasoning is not so great, give them the opportunity and take into account their opinion, trust them to complete responsibilities, and also foster dreams and goals. And then, of course, modeling behavior is very important. And the key thing from this slide is that adolescents who live in an environment where there's substance abuse, where there's intimate partner violence, are more likely to pick up those habits, and they become actually lifelong problems. And then, of course, provision and protection. This we all know this is a core role for parents. It's important not only to pay school fees. If you are not able to pay school fees, you, the parent, should go looking for the school fees, local chief's office, whatever, not sending the child to prostitution, which is a pattern of behavior that we're seeing, participating in school activities, and also creating social capital, a network of other caring adults who can support this adolescent. I'd like to give the example of the headmistresses of Kenya High. This is my alumni, and Moyadoret girls who are outstanding in not sending students who have problems with school fees home. They actually say it's a responsibility of the parents at the school to find the money. Even the provision of, say, sanitary towels or other things are done in a discreet way so that this adolescent is not demeaned and has a sense of confidence. The trip home to collect school fees have issues of physical safety, psychological threat, and opportunity for sexual predators. So if you have diminished self-esteem, you're more likely to engage in risky activities. I'll just draw your attention to this slide again from a community discussion on what do parents aspire for, and the strategies that they engage in, and what is taught to their children. And I think what you see is that we talk about reproductive health. We have whole government programs that are worried about adolescents. Very few parents actually are identifying this as an issue. And if you look here, only about 1 in 5 parents ever talk to their adolescents about abstinence or avoiding STIs or even avoiding pregnancy. So there's a gap between what parents should be doing and what is being done. So let me conclude by saying that the key thing as an adolescent is developing your human capital. To go from being a child to a responsible adult who takes care of yourself. Our role is to protect, build this capital, refine it, and then harness it. And this would take the whole community, so the parents, the child themselves, and the teachers and others. Thank you. Sorry, I have gone over time. I'm ready to take some questions at question time. Okay, but conclude that adolescence is a time of unprecedented promise but also peril. Because of that disconnect between physical development and cognitive development. But if we support them well, we can deliver the anticipated demographic dividend that is awaited for in sub-Saharan Africa. Now, that picture is of an older adolescent, a ballet dancer. This is Kibera. I picked a picture out of the Kibera, out of the internet, is of Kibera, and this shows the potential young people have. Thank you.
Thank you. Thank you so much, Professor Nduati, for a very detailed and excellent presentation. It's like taking us back to class. A lot of us, you've clearly described the stages that adolescents go through socially, cognitively, emotionally. And at the end, you've talked about what that means for parenting and shaping behavior. And I think that is extremely important now, given the fires that we are seeing in school, the unrest that we are seeing in school. I think what you talked about has very serious implications for how parents and how teachers are going to handle adolescents. You know, they said that the brain of an adolescent is like a car with a fully functioning fuel pedal, but brakes that are not working well enough. So thank you for that. And it lays a very good ground for the next presentation. And I'm going to welcome Dr. Florence Mugambi, she's presenting on behalf of Dr. Ruth Libon Masha, and she'll be taking us through sexual risk-taking and mitigation strategies for adolescents. So welcome, Dr. Florence, and please introduce yourself. Karibu. Also, kind request to keep to the timelines. It's 15 minutes, so that will be 10 minutes past 3. Karibu.
Thank you very much. And my name is Dr. Celestine Mugambi, not Florence. I work for the National AIDS Control Council in the Technical Support Division, where we do adolescents and young people programming. So I will be making this presentation for the NAC. Just allow me to share my screen. Please confirm you can see my screen.
Yes.
Okay, let me put slideshow. So we were asked to talk about sexual risk-taking and mitigation strategies for adolescents. Like I've said, my name is Celestine, I work at the NAC, and as the National AIDS Control Council, our mandate is really coordination of the HIV response, coordination of partners and the different stakeholders to ensure that our HIV response is robust and is actually working towards the targets as per our strategic frameworks. So I would just want to start very quickly by saying that HIV is a social problem and not a medical one. And so even as we think about HIV, SRH, and STIs, we really have to think about our programming like that. So even if we have rapid scale up of biomedical responses, like test and treat and putting people on ART in the context of HIV, that's not sufficient for us to control the epidemic. And we really have got to go before that and talk about behavior change. And Professor Nduati has laid the groundwork for, the adolescent brain. And in respect to that, let me just put into context who we are dealing with. And this is a slide that I have borrowed from one of my colleagues at the NAC. We have got 4 categorizations of human beings, let me call it that. We have got the baby boomers who are born between 1944 and 1964. So right now they're about 55 to 75. And the typical trait, so this is the pre-independence, post-independence generation, parents to many of us. The typical trait is that they were idealistic, they were optimistic about a new future, a new Kenya. They're revolutionary. I think they were unafraid to go out and chat, go to different territories and charted waters, and they're also collectivists. They really thought about the collective good of the society. Then we've got the generation next, who are born between 65 and 79. Now, these ones right now are aged 40 and 54. And the typical trait is that they're materialistic. they think about me, myself, and I. What can I get for myself? Education, a good job, a house for my family, a car, holidays, and what have you. They are also extremely competitive, and we're seeing this playing out in a lot of social media platforms where everybody is wanting to post where they are, what they are doing, and they're also quite individualistic. And then we've got the Generation Y, who are the millennials, who were born between 1980 and 1994. And they're now aged 25 to 39. The typical traits, they are globalists, they question a lot, and they're also very self-oriented, self-driven. And who we're talking about in this context is the Generation Z, or the iGen, who are born after 1995 and now are less than 24 years. And the typical trait is they've got an undefined identity. They like to dialogue a lot, and they're also very realistic. So when you look at the different brains of Generation Y and Z, for the Generation Y, these ones are optimists. They're very tech savvy. So somebody can actually be on their phone and on the laptop at the same time. And they possess decision-making power. They want to be discovered. They focus on the present, the here and the now. They spend a lot, and they communicate a lot through text. The Generation Z, who we're talking about, less than 24, these ones are realists. And they're tech in it. They can actually have 5 screens simultaneously at the same time, and they're able to focus on what they're doing. They're more influential. We see that on social media, and they want to work for success. I think it's a lesson for us all, because sometimes they are identified as not being very driven or self-motivated, but they do actually want to work for success. They are focused on the future. They do care about what's happening in the world and what's going to happen in the near and far future. They are also savers, and they communicate with images and symbols. For those of you who are parents who have got this age group in your house, if they were to send a text to their friend, you would not be able to decipher what exactly they're saying. So that is who we are dealing with, a completely different ball game for us. So even as we do our programming, we have to think about how to adequately engage them and program for them. So what are the numbers telling us? This is the population dynamic as per the Kenya Population Report in 2018. Projected Kenya population is 45.8 million, and 70% of these are below 24. So I think for majority of us, we are the minority. Approximately 32 million, 28% are between 15 and 24, that's about 11.45 million. And if you look at the life expectancy, we're actually living longer. So the males is 61 and the females is 65.8. So those are the numbers that we are talking about from a prevention perspective. This is just a diagrammatic representation, and this I have borrowed from our AOLP performance tracking tool dashboard. I'll talk about it in a little bit. If you look at the top right, where we've got the pink and the blue, that is the gender, 50-50 male and female. But if you also look at the new HIV infections by age, then we see that we have a lot of them within that age group of 15 to 24, and I shall be highlighting on that. So when you talk about vulnerability to HIV, to STIs, what really are the causes? And this is a diagram that we normally use in programming. And I just want you to note that 90% of what I'm going to present to you is outside the confines of the Ministry of Health. So the first one is cultural beliefs, early marriages, community taboos around HIV and SRH. We still cannot be able to openly talk about sex and sexuality in our community. And there's also power imbalances in relationships. And then we've got education. So low retention and transition rates in school, although we do appreciate the work that the ministry has done in 100% transition, but also promoting that all children actually access education. We've also got the attitude within the school system towards HIV, sexuality education, and the stigma that sometimes does occur within learning institutions. There's also lack of economic empowerment for this young group collectively, but we see this more so in adolescent girls and young women. Sexual and gender-based violence, whenever we talk about it as a country, we always focus on the girl child, but boys and young men actually do undergo SDPV, so we must also start to talk about it and think about it in programming. And then we've got low access to youth-friendly HIV and SRH family planning services. There's a lot of stigma around provision of these services to young people. We have got a silo approach to programming. If a young person wants comprehensive services, it is near impossible in most setups. They have to go to different clinics, different healthcare workers to get the healthcare package. And that begs the question, who does the adolescent belong to in health? Do they belong to the pediatrician? Do they belong to the internal medicine doctors, and what kind of policies do we have to actually ensure integration within the Ministry of Health. We've got lack of HIV and SRH information, which also leads to the low risk perception. And also we've got the most at-risk young people, the IDPs, the refugees, and those living with disabilities. Alcohol and drug use, I cannot talk about this enough. I think now if you go through Nairobi, I use Nairobi as an example, every street, every corner you go to, we're actually seeing a liquor store. I don't know if we stop to ask ourselves what is the impact of those kind of liquor stores being opened, especially in residential areas where we know children are passing every morning, every evening as they go to school. And of course, something else which is emerging is mental health challenges. But I do want to flag three things, emerging issues. I think the last 2 years have really taught us a lot. Emerging epidemics, COVID-19 really shook the world to the core. So we must also start to prepare and be ready for and have resilient systems that actually help us mitigate vulnerabilities of young people whenever we have emerging epidemics. Climate change. There was a climate change meeting a couple of weeks ago in Glasgow. I wonder how many of us actually paid attention, because the climate crisis actually is negatively impacting adolescents and young people. When you have got drought, when you have got floods in a particular area, when you have got famine, what does that mean for a young person who already is at risk? So it pushes them further into vulnerability. And these we see a lot in the indigenous adolescents, in refugees, adolescents with disabilities, or those who've got chronic illnesses, and those who are already marginalized because of gender or socioeconomic status. And then is the big monster now, political instability. We are already in an electioneering period. What do we need to do? How are we programming to reduce risk for this age group? So what are the numbers telling us? In terms of teenage pregnancies, this is just a graphical representation, but these are the trends from 2013 to 2020. I think the figures of 2020 is 231,578. If you look at the KHIS, or the Kenya Health Information System, 28% of all pregnancies registered were in girls aged 10 to 19. And a third of these are occurring in those 9 counties: Nairobi, Kakamega, Nakuru, Meru, Narok, Bungoma, Kiambu, Homa Bay, and Kwale. And remember, I've showed you from our wheel that a lot of these vulnerabilities are occurring outside the health facility. So what do we need to do? Well, so this is just, again, borrowed from our performance dashboard. Here, this is just a snapshot, but the dashboard itself is able to allow you to look at your particular counties. This is just a snapshot of 2020, again, showing Nairobi having the highest number of teenage pregnancies. So this is just a diagrammatic representation of what I had shown you before. New HIV infections among this age group, the blue is the male and the orange or the red is the females. Of course, we see an increase in adolescent girls and young women. In 2020, 42% of all new HIV infections in adults were in this age group, 15 to 24. That was about 14,400 new infections in that year. And 2/3 of these ones were actually in adolescent girls and young women. So what lessons and opportunities have we learned within the HIV response that possibly then could be used in other programs or in other sectors? I think number one is that we have learned and we must leverage on multi-sector action. We have to really program with the heart of adolescent girl, young man at the center and look at all the spheres of influence. So we have to engage the different sectors and leverage on their comparative strengths, even as they carry out their mandate. So what can the education sector do? What is the role of the private sector in mainstreaming youth affairs, Ministry of Labour, Social Services, sports, culture, the community engagements, and even the faith sector? So what is everybody's role? Number two, I think what is really important for us is the aspect of coordination. And I'll take you just through a bit of the work that we do at the NAC. We have a National Multi-Sector Steering Committee for Adolescents and Young People. And this has been guided by a strategic framework, which really has prioritized this age group as a priority population. Down at the county level, we've got the County Adolescents and Young People Technical Working Groups, and these ones are made up of diverse stakeholders, including young people themselves. We've also fast-track plans for adolescents and young people at national and at county level. A lot of the counties really have prioritized adolescents and young people in terms of HIV and SRH. Some have developed county-specific plans. Some have actually integrated AYP, HIV, SRH into their CIDPs. But I think also what is most important is the aspect of data. In Kenya, we have a lot of data, a lot of research that is happening. So we need to become the first utilizers of our data, not waiting for conferences abroad to go see what is happening. And so for us, we have developed with our different partners in HIV and SRH, what we call an AYP performance tracking dashboard. We have started small at looking at HIV indicators, SRH indicators, but we have also reached out to the Ministry of Education so that we can see what data from the NEMIS we can be able to pull. So this is just a snapshot of some partner data that we have, VCT, this is to their credit, and they have a hotline 1190. So just by visualizing it like this, you can be able to tell which counties where young people are calling the most from and what they are calling out. So just a snapshot with this one. Nairobi County has got the highest number of callers, and the majority are asking around pregnancy and birth control. So you're able to tell by county what are the most significant questions coming and use that for programming at the community level. We have to increase information and access for adolescents and young people through use of technology. Strategic partnerships for us at the NAC, we've partnered with the Ministry of Education as they were reviewing the curriculum. We supported them to develop the HIV and AIDS content. They have done family health education, which is the equivalent of CSE. So those collaborative efforts really must be fostered and ingrained in our programming. And then I think what is most important is that we have to leverage on the young people themselves. I told you they like to be engaged, but also for us, it's just not engagement, but holding them accountable. So what roles can young people potentially play in whatever response, HIV, SRH, STI response? They're very good community mobilizers and they can create demand for services. They're also very good educators. They tell us that they're more receptive to receiving information from an age mate or a peer. They can also help in service provision at community level. For us, I know we have engaged them to do condom distribution, support groups or network leaders. And I think this we've seen mostly in networks of young people living with HIV. And they're also very good role models. And so for us at the NAC, we have institutionalized this. We've got what we call the Maisha Youth County chapters in each and every county. So these chapters were a group of people nominated by the county. We sat down, trained them on advocacy toolkit, and they're actually very closely working with the county governments. But what is most important is that they're reporting back to the national systems. At the NAC, we have a community reporting tool where we're able to get data from the community-based organizations. Previously, we just had HIV, but it's now been expanded to include TB and malaria. So when the young people are reporting, then when we're doing our reports and giving them feedback, we're able to say that this is the contribution of young people in Kenya to the HIV response. So I think also, in as much as we want to engage young people, there has got to be an aspect of mutual accountability. Number 5, we have to integrate. Our approach to the young person in Kenya has been completely siloed. And so we have to think about bringing everything under one roof, under one house, so that then when a young person enters a health facility for services, they can be able to get everything. So we need to move from the diagram on the left to the one on the right. And lastly, we must rethink adolescent programming from a human-centered design. Really think human-centered design just means you think about them at the core of the response, but you also use them to co-create ideas and solutions to the problems that they are facing. So this is just a diagrammatic representation. This is credit to Dr. Christine Mambugu. This is not mine. If we're going to be talking about giving information, we must think about the full life cycle of the human being, right from pubertal maturation. For both boys and girls, information is important. Menstrual hygiene education, sanitary towel distribution, and treatment for dysmenorrhea. When you think about teenage pregnancies, we really have got to employ abstinence and prevention strategies for both the boy and the girl. Early pregnancy detection, so a lot of community engagement needs to be done, ensure they deliver safely, and we support them also to do exclusive breastfeeding, postnatal care, but most important, mental health support for these young mothers, for these young fathers. We must also think about adolescent health, and I'll confine myself to the confines of reproductive health, but you can expand it to any other disease program that you are engaged in. And then we think about transition. How do we prepare this young person to transit from being a child adolescent into adulthood? So which community actors, which community players do we need to engage with to ensure that they're adequately prepared? We have developed their critical thinking skills, they're able to negotiate efficiently, and they have got life and career goals. So that is, in a nutshell, the work that we have done at the NAC, the lessons that we have learned even as we do adolescent and young person programming. But I think what is important to remember is that in the Ministry of Health, as healthcare workers, I'll speak as one, we see the end result of a problem. We don't have the solution to that end result because, for example, giving family planning to a 10-year-old may not be the solution. How do we ensure that a 10-year-old girl does not get pregnant? What do we need to do? So I think as ministry, we must be deliberate to reach out to the different sectors, hold everybody accountable to ensure then that we safeguard the lives of these adolescents and young people. So thank you very much for listening. And I think, Chair, I have kept to my time. Yes, with 2 minutes to spare. Thank you.
Yeah, thank you so much, Dr. Celestine. Sorry, I called you Florence.
No
Yeah,
worries, it's fine.
Yeah, that was a really good presentation. You've highlighted the multiple factors that increase vulnerability to HIV among youths and adolescents. And it's important that we understand that a lot of these problems are very complex and cannot be looked at in simplistic ways, and also cannot be managed by any one single sector or any one single government ministry. And you've clearly explained how we need multiple people to hold hands together. I was waiting to hear criminal justice system when you talked about 28% of pregnancies being for kids 10 to 19. For me as a mother, that is extremely horrifying. And I wonder whether working with the criminal justice system is something that you've thought of as well. You've also talked about integrating care so that we have one-stop shops for adolescents. That is in the Kenya Mental Health Action Plan as well. So we look forward to having the Ministry of Health and NAC and Division of Mental Health working together as well to realize that. One thing I would wonder is what does that take, and that can move to the discussion. What does it take to have a one-stop center for adolescents? Would it mean that healthcare workers need to be trained? Would it mean allocating more financial resources? How is that exactly realized? And we can have that go to the discussion, question and answer session at the end. So thank you so much. And coming up next is Dr. Adrian Njenga, who will be taking us through risk-taking with substances and mitigation strategies. Dr. Adrian, kindly introduce yourself, and I also request that we keep to the 15-minute mark, which means at 3:30 you should be done. Karibu, please introduce yourself. Is Adrian Njenga with us?
Yes, I am. Can you hear me?
Yes, we can hear you. Karibu.
Thank you. Good afternoon. Good afternoon, everyone. My name is Adrian Njenga. I work with NACADA as a to address the same concerns. At NACADA, we are also very concerned about the rising problem of alcohol and substance use. And again, this is a very complex issue that requires the input of different stakeholders. And that is what I would like to highlight today, some of the interventions that we've been able to put in place as an authority, but also to also pose a call to action so that we can also rope in the involvement of different stakeholders so that we can be able to address this problem adequately. To start off, let me just give you a brief background of NACADA, because most people also misunderstand our mandate. We are a state corporation under the Ministry of Interior and Coordination of National Government. And we've been established to coordinate, as I pointed out earlier, a multi-sectoral campaign aimed at prevention, and prevention is key for us. It informs close to 60% of the work that we do. Then controlling the access and availability of these substances. And then lastly, to mitigate the impact of alcohol and drug abuse in the country through the provision of treatment and rehabilitation services in consultation with different stakeholders. But the primary area of interest for us has been drug demand reduction, which relates to the aspects of drug demand prevention and treatment for people who have developed substance use disorders. Just to remind you about this, though, Dr. Wambugu yesterday and Professor Nduati also alluded to some of these factors. Why do young people use drugs in the first place? And we've basically managed to highlight three broad reasons or three broad factors that influence young people and drug use. But also it's important to mention that substance use is largely an interaction between an individual's personal characteristics and various micro and macro level environments. And Dr. Wambugu did a good job yesterday of laying down the two environments that we also need to take cognizance of as we address some of these risky behaviors. But with regards to the individual factors, some of the issues that we are seeing is that there is very low perception of harms caused by drugs. This could be caused by various factors, including what Professor Nduati pointed out, that when young people see or adolescents see their parents using some of these substances, then their perception of harm is also diminished the same. There's also peer pressure. This is a very impressionable age. So what they see their peers doing, they're also likely to take up. Then there's also rebellion, poor role models that we have in the society. This could be us as parents ourselves or even teachers within our school setting. Then they also use substances as a coping strategy to control anxiety, fear and stress, lack of purpose in life, and then looking for pleasure and curiosity. Those are some of the individual factors. Family factors, and I'm happy that, again, Professor Nduati really belabored on why we need to focus on families, because for us, that is a primary socialization agent, and I'll be sharing a bit about what we are trying to do to impact the modern day parent to be able to be aware of some of their roles with regards to addressing these issues. But also some of the factors that may cause them to use substances from the family level, the conflicts that they experience at home, including family breakdown, then the different parenting styles that we've adapted from permissive, neglectful, authoritarian. It will be interesting even for you to reflect as a parent. What is your parenting style and how does that impact on the behavior taken up by your child? Then there's also overprotection by the family, including the parents, including not allowing children to think and do activities for themselves. Then also the expectations that we levy on the children, that they must be attain a certain grade, they must behave in a certain manner. Some of that could also lead them to starting to use psychoactive substances. Then there's also now the other issue which is at community level, and again, Dr. Mugambi alluded to some of this in our presentation earlier, that we are seeing an influx of wines and spirits shops within the city and even within the residential areas. And that is also a contributing factor. Inadequate enforcement of laws and policies. We already have enough laws and policies, but the challenge that we have is the full implementation of the same. Including selling alcohol to minors. You can clearly see that these are children, they're in uniform, but we still have situations where people actually sell alcohol to them. I don't know if you remember of an incident just last week of a driver who dropped off some students in a police station because they were consuming alcohol inside the matatu, and at the same time they were taking cannabis. But unfortunately, as a society, how we responded to the issue was that the driver ended up being fired by the particular circle. So with regard to enforcement of some of these legislations, we still do have a challenge. Then we're also seeing an increase in positive attitudes and norms and beliefs about alcohol and drugs. This is either espoused by our role models who have shown young people that it is cool to take some of these things and you won't necessarily be affected by consumption of the same. So what is the status in our country with regards to this particular target group? So NACADA conducted a survey in secondary schools in 2016 and a follow-up of the same in 2018 to ascertain the levels of knowledge, attitude, and practice with regards to alcohol and drug use. And the findings were really startling. And I'll start with the primary school section because that's the earlier group. And as you can see from the presentation, they are preferred. At the time when we conducted the study, we saw an increase in the use of prescription drugs. And this could largely be because it's easier for them to access the same because of the weak regulatory environment then, because we did this in 2018. And PPB has since enforced some of the legislations pertaining to the same. The second preferred drug of choice was alcohol. And this is a problem across the country, not just specific to adolescents. Then the third drug of choice was tobacco, and tobacco is now in very many, has very many types, from the cigarette that we know, to snuff, to shisha, which is still a problem even after we have banned it in this country, and to the emerging new tobacco products, including Lyft, which has since been banned, but you'll still find pockets in this country where young people are able to access the same. Moving on to their counterparts in secondary school, the leading drug of choice was alcohol, followed by, again, prescription drugs. Then there was miraa, and lastly, tobacco. When you contrast that against the national and a study that we conducted nationally, the leading drug of choice for Kenyans aged between 15 to 65 years was alcohol, with, and at the time, the current use was at 10.4%, followed by tobacco, miraa, and bang. So you can see what Professor Ndwati was saying, that young people are aping what some of the things that they see their parents doing. And you can see from the numbers, they're not very far off from the picture that we are seeing nationally. From these same studies, we also came to realize that we have a situation where young people are mixing more than one substance, what we call polydrug use. And we simply define polydrug use as use of 2 or more substances concurrently or simultaneously. And that is what has contributed to the high increase of prescription drugs across the country, because people are mixing 2 substances, a psychoactive substance and a prescription drug, so that they can be able to alter the side effects, the immediate side effects or the hangover effect that they get to experience from using their preferred psychoactive substance of choice. Again, parenting and the family setting came up as a worrying trend, especially as we talk about adolescents. From the findings, young people told us that living with a single parent is partly a risk factor, especially those who are brought up singly by fathers. Perhaps it's because fathers are naturally not nurturers. Yeah, so that we need to interrogate that further. Then there was also the issue of pocket money that is not regulated. Then if you have a family member or friend who's using alcohol and drugs, that could also pose as a risk for the adolescents to start using. Then interestingly for us, young people also told us not being an active member of a religious group or a club may also predispose you to starting to use some of these substances. So our conclusion this far from the studies that we've conducted, that the family is by large the primary socialization agent for adolescents. And it's supposed to be a protective factor for the same. We are seeing it now becoming as a risk factor. And even during COVID, the time that they had closed school for a pretty good amount of time, we were getting a lot of reports about how young people are being initiated into alcohol and drug use right from the home environment. However, we need not to panic. From our studies, we have more young people who are not using than those who are using. But as we know, it's important that we also start to help or to provide access to services for those who are using, because the adolescent stage is very, very key and young, and it's the best time to build positive health habits and limit negative ones, because these get to go with them into their adulthood. So what are some of the interventions that NACADA is implementing this far to respond to these challenges that we are seeing? We are basically implementing our programs in 4 settings. And these are settings that NACADA has borrowed from a document, our strategy that was developed by the United Nations Office of Drugs and Crime with regards to what actually works for alcohol and drug prevention. Yesterday, I think it was Dr. Mango who mentioned that there is need to develop and implement evidence-based interventions so that we can adequately respond to these problems. So the interventions, number 1 is within the family setting as a primary socialization agent. The second most powerful socialization agent for children and young people happens to be the school. Then we also have programs at the workplace setting, and lastly at community level. Now, with regards to the family, of course, again, Dr. Mbugu laid the foundation with regards to what needs to be done. And for us, again, this issue needs to start at the prenatal and postnatal care visits. Then this is also followed up by home visits by CHIUs so that they can be able to follow up on new mothers. Then it's also important that we equip parents with skills on parenting. And this is a campaign that we have been implementing the last 1 year, particularly because of COVID. And this is a program that we've been running in collaboration with different stakeholders using mass media and social media so that we can be able to equip the modern parent to respond to the challenges that they are facing as a parent, and also with regards to their role as parents. The second area of intervention is within the second most powerful socialization agent for children, and that is schools. And we believe, just like Dr. Ugambi pointed out, that keeping children in schools is actually a protective factor. So we are working with county governments so that we can ensure that within the ECD programs that they are running, we can track the progress of children within the same institutions. We've also worked with KICD to mainstream the issues of alcohol and drug abuse within the life skills component in the curriculum for CBC. Additionally, we are running a life skills training program whose objective is to equip the adolescents with relevant skills and accurate information on the issues of alcohol and drug abuse so that they can be able to make informed choices. The other aspect that we are working closely with the Ministry of Education and other actors in the education sector has to do with classroom environment improvement programs. Then also advocating for policies to retain children in school. So we're encouraged by the reports by the Ministry of Education about 100% transition, because we strongly believe that schools are actually a protective factor. And when children are home for a very long time because of the challenges within our community, then they are largely predisposed to start or to initiate and use substances. And also, again, I can't belabor on this. The other speakers have also talked about it, addressing mental health disorders and psychological vulnerabilities. And then an area that we've worked the last 1 year with the Ministry of Education and other education stakeholders has to do with how do we manage this problem of substance use in schools. And we've been able to come up with guidelines to support the ministry to address this problem at school level. So this is an image of our life skills program that we are running in 19 counties. This is a pilot program. So we are running this in 19 counties, 174 schools so far. We've trained 289 teachers who actually deliver 12,000, shy of 12,000 learners with this LST information. And this was a comment from one of our teachers in Kwale County that the program works. Her pioneer class topped in the zone for that particular national exam, which was in 2019. Then additionally, supporting schools to address the problem of substance use within the setting, which also includes addressing their immediate environment, because some of the shops, for example, around schools act as places where these young people and children can access substances. So we've put in place some guidelines to help head teachers, school principals, and the larger communities within the school environment on how they can, number one, prevent, and number two, in the event the problem surfaces within the institution, what steps they can undertake to be able to respond to this issue. Last year, because of the challenges that we had with COVID, young people and children were at home for a bit of time, and we wanted to hear from them. How is this pandemic affecting you, especially because now you are forced at home? And we had a national arts and essay competition, and we invited them to submit to us in now utilizing various forms of art. How is COVID affecting you? What is your story like? What are some of the challenges that you're experiencing? What are some of the good things that you've been able to do with your time for the 8 months that they were at home. And we got some very interesting feedback. This was actually what I've projected here is one of the images that we received. And you can see it's a mix of emotions from the young people that participated in this competition. So that is what we are doing with regards to schools. We've also developed information booklets for children and teachers so that they can be able to and also engage their teachers, their learners. It's important to note that this information, we've provided accurate information, because at times we overshare, and in the process, we're actually introducing new drugs to our children without our knowledge. So when you talk to them about drugs that have probably not encountered, that may come off as a risk. So we've put together a few 5 information pamphlets that are available on our website for anyone to download in whatever space they're in, and they can be able to have discussions with their children on the same. So the age sets that we've worked with is from age 6 to 8, 9 to 12, 13 to 15, and then the other set of adults, which ranges from 16 to 18. So as I conclude, I need to point out something that Dr. Mugambi shared, that we need to move away from siloed interventions, because really our future depends on, as Dr. Magwa shared yesterday, our future depends on how prepared our youth will be. Remember, a single stick may smoke, but it will not burn. So we need to collaborate as different actors in this area, so that we can be able to support our children be prepared for their future tomorrow. Thank you.
Thank you so much, Dr. Adrian. I know there's lots of questions about substance use among youth, and people can either put them in the chat box or jot them down and can raise them at the end of this session. It's true that substance use is a very big problem among adolescents and youth in Kenya. If you look at the median age of onset globally and that in Kenya, there's a huge difference, about 16, 17 globally and about 11 in Kenya. And I think NACADA has found that kids as young as 4 years are beginning to use substances. So we can see how huge the problem is. But it's also refreshing to see how NACADA has led the way in implementing interventions, in developing policies and guidelines, which is really excellent. So thank you so much, Dr. Adrian. Coming up next is Dr. Josephine Omondi. She'll be taking us through the biology of mental health illness in adolescents. Dr. Josephine Omondi, I'll request that you introduce yourself and then you take it away. Again, you have 15 minutes, which makes it 3:50. Karibu.
Good afternoon, colleagues and fellow listeners. My name is Dr. Omondi. I am a child adolescent psychiatrist working at Kenyatta National Hospital. Now, I'll take you through youth mental health within a society on transition. I hope it is clear as I've introduced myself. It's blocked. Hello. Is something wrong? Hello.
We can hear you.
Okay. Okay, yeah, there's somebody moving the slides. And I was wondering if he's on it. Now, when we talk about, Professor Nduati had already highlighted this very clear. The youth period, there's a big intersection between the adolescents and the youths, the early adolescents, the mid and the late. And you'll find that the mid-adolescents up to 25, those now constitute the youth, which of course goes up to 35. But we'll find that in their, maybe later on in their development, you'll find that sometimes the youths, you may go up to 30 years and still call them adolescents and not just the youths, because of the various reasons, including some that had been highlighted by Professor Nduati. Next slide. Next slide. Now, in adolescence, which had already been spoken about, the transition of physical, psychological development that occurs during that period between puberty and the legal adulthood. Now, during this stage, there is the biological growth and development, and there is actually an undefined status. And some of those children, one time they are little adults and other times they are little babies. So it is really an undefined period. There is increased decision making. Some of them are totally irrational, but some are good. Then there is also increased pressure. There is lack of identity. And there is the period of formation of relationships. So there's a lot that is going on. But then from adolescence, they move to the youth. Next slide. Now, when we talk about mental health in adolescents, and I wish we could all the time highlight mental health as we provide services to these youths, because in mental health, which is a state whereby we look at the achievement of the individual, youth and adolescent, whereby they are able to deal with day-to-day challenges, and then they're also able to contribute to the society. Now, in this regard, this cannot be done alone. They need life skills in terms of self-help skills, in terms of personal hygiene, communication skills. Many of these young people don't know how to communicate. They have to be reminded. Sometimes they use their emotions to communicate. Assertiveness, being able to say yes or no when they actually mean what they are saying. Being able to negotiate what they want and how they want it. Being able to prepare good meals and in a clean environment, and being able to work in a team and produce material that is useful, and then, of course, increased decision making. So all these life skills help these young people to be able to maneuver the mental health and be called mentally healthy. Next slide. Now, I know Professor Ndweti had highlighted some areas, but this is just a diagrammatic representation of the brain. And she had said that there are certain areas that of the brain that grows very mature very early, and others mature very late. Now, by the time the child is reaching 9 years, the building blocks of the brain is complete. However, the maturity differs throughout childhood, adolescence, and then into adulthood. Now, the growth of the brain starts posteriorly and moves to the front, such that the frontal lobe, which is important for executive function, here we are talking about decision-making, thinking, planning, organizing, controlling, and being rational. That is the last area that develops. And it is very interesting that during the adolescent and the youth period, this is the time where there is maximum reconstruction. And this maximum reconstruction eventually ends around 24, 25 years. However, there are those who the reconstruction continues up to around 27, 28. There are a few of them, but they do. When you look at their behaviors and their thinking, you'll find that, yes, they have reached 25, but the construction has not completed. And so they engage in totally inappropriate behaviors. Next slide, please. Now, what are the issues here? Some have already been said and others we're just highlighting. There is information overload. And I was listening to the presenter who was talking about Generation X, Generation Y, and the bloomers and the rest. Now, at the moment, our youths and the adolescents have a lot of information. And they are always seeking for information because there's always something new and thrilling. But within the process of seeking information, they need to remain relevant to their peers and also conform to the expectation of their peers. Apart from that, there's also the societal expectations and achievements that must be reached. But within this context, there is still the reconstruction. What Professor was talking about, there is a discordancy between the maturity and the physical and the social development. The four of them don't go hand in hand. So what happens here, apart from the neuroplasticity where the brain is reconstructing, there is the influence by parents. And here, this is a key point for all of us throughout this country and throughout the world. There is a big influence of parents. If the parents don't influence positively, something goes wrong. There is also the environment and then what is being consumed. So it is important to note all this, and maybe we shall look at it later. Next slide, please. Now, what are the controls as we help these young people? The controls are the values. What values have they gathered from childhood to the youth period, and now they are moving to adulthood? What values have they gathered? What achievements have they had over time? What is their purpose in life? The previous presenter who was talking about substance use, he also mentioned something about one of the protective factors is having a purposeful life. Some of the adolescents don't have any purpose in life. They don't know where they're coming from and they don't know where they are going. So this is one of the key areas also, acceptance within their families and also acceptance within their group and creation of a balance. Again, the parental place comes in and other authority figures. We have seen over time that parents are, the parenting is coming less and less. And then there are other parents who are coming in to be able to parent these young people. And here we are talking about organized homes, foster parents, and such aunties and uncles. So there are other authority figures who are coming in to parent. But do they give the values that are expected? What are the checks and the balances? The checks and the balances in maneuvering this period: 1, good sleep, 8 hours and even more. But I can assure you that many of these young people are not sleeping. Why are they not sleeping? They are worried, or they are recovering from something, or they are in the social media. So they are not getting good sleep. And that is also interfering with their moods and their development. Frequent exercise is very important. And it's very interesting that the COVID has stopped this. And when you talk to these young people, they tell you that those who have completed school, they do exercises. But those who are in school, PE lesson is only once in a week. Games is only once in a week. Other times, they'll wake up at 4 a.m. and they are going to sleep at 11 or 12 midnight. So then they are not getting enough sleep. And this is one of the contributors to the pressures that we are seeing in the schools today relating to banning of schools. There is a regular balanced diet that they need to have, but some of them do get junk. So when they come to the clinics, we have to ask them, what does your meal constitute of? Some will just tell you that, oh, it is strong tea because I'm checking my weight. Or they're just taking bread and milk, or bread and yogurt. But then that cannot last for the whole day. It's not a balanced diet for the whole day. So as much as they're checking their weights, they need to get a good balanced diet. And then, of course, the achievements. When one is able to achieve, it increases their level of confidence and further engagement into good practice. Because we know that good behavior enables and bad behavior disables. Then, of course, the healthy relationships that they engage in. This will help to boost the controls so that they can gain healthy development into adulthood. Next slide. Now, what are the problems? The problems are the maladaptive behaviors. And the maladaptive behaviors come in various forms, from the precocious sexual engagement to inappropriate sexual engagement, to self-cutting, to substance use, to suicide and para-suicide, and major depression. And then the others are full-blown psychosis. And then there are those who really have difficulties with adjusting to the environment. As much as there are lots of challenges that they are encountering, there are those who are totally unable to adjust to the environment despite having a good support system. So they convert into symptoms, and they are always seeking for treatment for physical symptoms, physical illnesses which do not have organic basis. But when you explore more, then you realize that they are suffering mentally and they are not able to say. Then there are those who have who experience antisocial behavior and later lead to crime, and crime in form of stealing, burglary, and also major thuggery with use of weapons. Next slide. Now, the other day, somebody was asking me that if, for example, I come to you and I am dirty, does it mean that I am psychotic? Of course, I said no. That is just one of the manifestations of illness. When you look at a patient or you evaluate a patient for mental illness, the first thing you look at is how they present themselves. And so there's the deterioration of personal hygiene. It's one of the major symptoms and signs of mental illness. The way one is dressed, probably also their walking style, whether they're stooped or they're walking with their head up. Deterioration in academics is another key pointer, and we have sometimes we have had parents who are bringing their children to our clinic because the child is not performing well. Now, when you explore further, you realize that this child has had this problem before, but there's escalation around adolescent. And sometimes they're actually getting into a psychotic illness. So there's also disorganization in other behaviors, poor sleep, and excessive or very little appetite. Sorry for that type of poor. Next slide. Yes, now what interventions can we apply so that we help these youths to maneuver their life in a healthy manner? Parenting. That is a key, just like we used to talk of during Kibaki's era. We used to talk of infrastructure. Now we need to talk about parenting. Some of those children have parents, but the parents are not there. They are not there emotionally, they are not there physically. So the children have to look for other places where they can vent their problems or where they can feel heard or even taken care of. Then space for venting without judgment. One of our colleague who presented on substance use talked about these successful school programs. Now, I believe that the school programs would be very useful, school programs with regards to mental health, so that these children can understand where they belong and they can work hard so that we prevent some of the mental health problems. More so the anxieties, the depressions, those ones can be prevented. Now, there's something I forgot that among the depressive illnesses that these youths present with, there is one that we call the Google depression. Now, the Google depression, I've seen it among youths who they feel a little bit of headache, they are not very happy that day, then they'll start Googling information. When they Google the information, they apply it to themselves. Then they come to the clinic and they tell you that I am depressed. But actually, when you scrutinize the symptoms, they are not depressed. So it is important for clinicians and others to be able to scrutinize the symptoms before they decide to medicate them or not. Then finally, the recognition of the abilities of the youth. I know in Kenya, we have emphasized academic achievement, but what about sporting achievement? What about other social achievements that we can focus on our children to help them in their self-esteem? The Ministry of Education, we're trying to help these children to have all children integrated into education system, came up with this CBC program, the competency-based curriculum. Now, it has its good aspects and it has its bad aspects. But for me as a clinician, the good aspect is that the child will be able to formulate their own pathways to be able to recognize where they fall. If the child is good in sports, then the child should be helped to achieve in sports. If the child is good in music, that is the area where they will be helped to be able to achieve in music and such like. So there are those who are academic and they're doing very well, then there are those who are good in other areas. So the CBC is an advantage, and I believe it will also help the youths who are upcoming, and the adolescents who are upcoming and the children, so that they can maintain their confidence and keep them away from these maladaptive behaviors. Thank you very much.
Thank you so much, Dr. Josephine. I really like that you highlight that the bulk of interventions for mental health for youth should be promotive and preventive. And that is exactly what WHO recommends. Sometimes we focus on having care within hospitals, in institutions, but that really should be just a fraction, a small fraction of what the entire range of mental health services should be. So the bulk of this should be encouraging things like physical exercise, teaching parenting skills, for example, encouraging young people, teaching about good dietary habits. And this, the way you said, can be delivered in school settings, in primary care settings, in multiple other settings that youth frequent. So thank you so much for a very informative presentation. Questions again can be posted to the chat or can be raised at the end of this session. I'm going to welcome now Dr. Simon Njuguna. Dr. please confirm that you're available right now.
Yeah, I'm available. Yeah, so just share my presentation.
Okay, all right. Dr. Njuguna, would you like to introduce yourself as I share, or someone else has done it already? Okay.
Yes, so thank you, Dr. Florence. My name is Dr. Simon Njuguna, the Director of Mental Health. I'll be very brief because of time. I think I'm supposed to talk about the initiative we are undertaking at the Ministry of Health. We can have the next slide. So basically within the mandate of the Ministry of Health or the national government, our key function is formulating policies and strategies to be able to give directions and roadmap on the adolescent mental health services. So basically we have the Kenya Mental Health Policy, and recently we had the Kenya Task Force report on mental health and the Kenya Mental Health Action Plan. So these are documents which we have clearly stipulated the key areas of actions as to address the adolescent mental health services. So the key strategic action is trying to look at, first you have identified adolescent as a vulnerable population. And so strategic actions are geared towards looking at reducing or mitigating risk factors in terms of their mental health, and also addressing their resilience in terms of protective factors. And so the strategic directive of the Mental Health Action Plan is to have very targeted programs and services towards the adolescent. More to that, we go ahead and provide the capacity building and technical assistance to the various stakeholders. That's mainly the county governments which are providing services, and other ministries, state department and agencies, so that they can be able to implement the various programs. Within our action plan, we have specific indicators which basically will be able to help us monitor and evaluate how the programs and services among the adolescents are going on. The next item is around public awareness on adolescent mental health across the sectors. Basically to tell them this is what we have as key directive of the policy. These are the key targets within our action plan, and what is expected of them, and then be able to build a partnership and collaboration with these stakeholders so that they'll be able to invest around those areas, and then we'll be able to get the necessary data. So we are also working around our information system and data collections so that we are able to monitor and evaluate the various services targeted towards young people, the adolescent, and also be able to identify the various needs and the burden within our population. So one key thing we also need to mention is the issue of screening on issues of mental health problem among the adolescent. And we have thought the best way to approach this is integrating this within the various other services, the HIV services, the NCD services, and school programs, so that we can be able to detect and have our intervention to all these problems. Key intervention also is the issue of mental health and psychosocial support services. And this has been very crucial, especially this time of the COVID, but then also from time to time, children are going through various adverse life events, and we should be able to provide them with this mental and psychosocial support. So mainly, the services to the young people and programs should be very well targeted. There are those which will be universally targeted, but those will be very targeted to those with following screening, and we are able to identify they have specific problems. So basically, those are the key initiatives. I would show you the key documents which are great importance in terms of reference. Look at the next slide. So the Kenya Mental Health Policy 2015-2020, 2030, very, very specific on what we need to focus for the young people in terms of services and programs. Then the WHO Health Adolescent document on helping adolescents to thrive. Really focuses on 4 areas, trying to see the policies and legal frameworks are well put in place so that we can promote and protect adolescent mental health. It also looks at the areas of the various environment, that we can create an enabling environment in terms of adolescent mental health, either in their homes, in their schools, in their workplaces, and also as they socialize. And then also there we have the Kenya Mental Health Action Plan, and also the necessary links you need to look at, so that as wherever you are coming from, whether it's in the education sector, social sector, security sector, as the key areas of the interventions and programs. And as a ministry, we should be able to work with you to give us the necessary technical guidance, help in capacity building. Also areas of system strengthening in terms of human resource, other key investment and resources you may require. And then we should be able to get the data, because these will be able to help us monitor the progress in terms of our interventions. And we are able to measure whether we are making any progress. So I think basically that's what I have for today. Thank you very much. And probably I'll be available for any questions or clarification. So thank you.
Thank you so much, Dr. Njuguna, for highlighting some of the activities that Ministry of Health is doing in terms of adolescent mental health. But I'd also like to emphasize that these documents are really key, and they highlight the priority areas that the Ministry of Health has is really prioritizing for adolescent mental health, specifically school mental health, the life skills training, as well as parental skills. So for people interested in implementing programs for mental health for adolescents, those are the ones that have been identified for being prioritized between now and the next 4 years. So I'd like to welcome now Kemunto Kenani from the Ministry of Education. She'll be taking us through the initiatives for adolescent mental health by that sector. So Karibu, and please introduce yourself, then go ahead. Is Kemunto Kenani here with us from Ministry of Education? Okay, so as we wait for her to log on, we are going to have the next presenter, Hilda Cheserek, who's going to take us through adolescent perspectives on risk-taking behavior. Karibu, Hilda. Hilda, begin by introducing yourself, then go ahead.
Hi, I'm Hilda Cheserek, a peer mentor at Moi Teaching and Referral Rafiki Center. And I'm going to take you to the slides of adolescent perspective on risk-taking behaviors. So I'm going to start my slide. Next slide, please. Why do adolescents engage in risk behavior? One of those risky behaviors are unprotected sex. The main thing of doing unprotected sex is for exploration. As adolescents, we like to do new things and practice how do these new sex feel like? How does it take us? And then how do it feel? So for us adolescents, like, as we normally say it, we cannot eat banana with the covers. So you can't eat the sweet with the wraps. To fit in to other peers who engage in sex. So like, if you are in that certain group of adolescents engaging in sex, you'll feel you're out, you're not among the same peers. And then to build a trust. For example, my boyfriend, if I don't engage in sex, they'll say, so auniamini, that is what we normally say. I cannot give you sex if you don't trust me. So you have to prove the love that you share is to have sex. For financial support from sponsors or peers, this is financially like to maintain our class. And then for the boy child to know his sexual capabilities, like if they engage in sex, they will know like, oh, so if this penis can work, so they practically like, they want to know if I can bear a child, if I can give a lady a child. Then the allergies of condoms. For example, most adolescents say, when we use condom, we have some side effects like scratching, the condom is not effective, it tears apart. Those are what we say. Then we fear to buy condoms. For example, I cannot go buy a condom in a chemist where a fellow mother can sell it into me. It's like a taboo on us. Next slide, please. This shows how we fear to take condoms. So it says, pale chemist, uzia hawa misi na haraka. That is the fear we have. So instead of going to buy condom or to access condom, we tend to do unprotected sex. Next. So another risk is drug and substances. To take them away, to keep them awake, to enable them study for a whole night. That is the perspective we have as an adolescent, as a young people. For example, if I take bang, it will make me feel I'm high, I'm on that point. I'll do my work effectively. Accessibility of alcohol, even at home. For example, if parents are selling or are brewing alcohol or any kind of alcohol, it is easy for me to access that alcohol. That is why we engage. The environments make us take the alcohol to release stress, either at home, school, or relationship-wise. At home, maybe there was burial, there was something of the sort. And then in school, maybe there's failure and poor performance. So if I drink alcohol, I'll release the stresses that are in school. In relationship-wise, when I'm heartbroken, that is the only place I can think about. So how it feels and how it tastes. That is, if you take alcohol, you like, for example, if you hear these drugs and substances, if you hear bang, if you hear alcohol, so you'll have that eager and curiosity to know how alcohol and bang taste like, to feel high. In terms of you are in certain age, for example, in that picture side, it shows how this female shows her figure and how big she is, but in reality, it's a very tiny person in there. But when they feel high, that is how they see themselves. Then to have fun. It's just when you're mostly, even currently in our society, most birthday parties are considered alcohol parties, something of the sort. So that is the fun part of it. And then to fear to miss out. So when we, like my peer group is taking alcohol or is doing alcohol part of it. So I won't tend to miss out of that peer group. So I have to take in the drugs and substances so as to fit in that peer group. And then to improve my self-esteem in that, when I take some alcohol, I can face any, for example, alcohol, I can face any challenges, even bang, I can face it. That is how we perceive it. Next slide, please. Next slide. Sexting and pornography. Why do we sex chats or do we see pornography? For exploration and experimenting on sexual orientation. So when we see these pornographic sites, it's like we will want to tend to practice what the other sites are doing to lower self-esteem, in that I cannot face any guy and say, I fear myself because I cannot face and say I want some sex. So that's why we sex chat. They prefer to sex chat instead of practicing sex. And then fear of missing out. When a certain group they talk about sex chatting, yesterday I talked with my boyfriend, so and so, blah, blah, blah. So next time, if I practice the sex chatting, what I had in a peer group, that is when I'll feel I missed out. So I'll tend to fit in that community. Technological advances. For example, our society or our Kenya, it has not blocked or prevent any adolescent to access any site, any pornographic site. So when they see it and a parent offers this kind of television it enables somebody to access anything. There's Wi-Fi, so you cannot be blocked because you are above 18. You can just access it anytime. And then easy accessibility of social media, I've talked about it. Then the parents' absenteeism. Most of our parents currently tend to look for money most of the time instead of being with their kids most of the time and talk about how life is. So majority of parents miss out when adolescents have challenges in here and then. Next slide. Abortion. Why do we tend to abort? We fear responsibility. For example, if I'm a student, I'm not financially stable, I'll be ranged in a certain category. I'll be somebody's mama. So we fear that responsibility of being taking care of a child. Then maintaining physical appearance. Like for us ladies, we like to maintain our figure. Even if we are parents, we still want to maintain our adolescent, our youth figures. Then fear of disclosure to parents. This is a mistrust. When a parent trusts a daughter or a child, when they come home with a pregnancy, they will see that the parent has lowered their trust on them, so they tend to abort it to maintain the trust in the parents. Stigma of being pregnant. Obviously, this is true because when I'm an adolescent, I won't, my peers or my fellow young adolescent won't be able to be open to me the way I was previously, when I'm now pregnant. So we tend to abort it because of fear of stigma of being pregnant. Then pressure for the sexual partner. So when a boyfriend forces you, I won't be able to be responsible of that pregnancy. So we tend, because of the pressure inserted on these adolescents, we tend to abort it so as to maintain our sexual partners. Poor information and accessibility of contraceptive. Most of our adolescents don't know that contraceptives are offered anywhere, so we fear those going to access contraceptive before getting pregnant. So we get pregnant, then later get the consequences of aborting. And we don't know if abortion we take abortion as a privilege or a good way to do it. So we also say for contraceptive, it's considered for those people who only are married or are in a family or 1 to 2 children. To continue with studies. Obviously, we abort it so as to continue studies and pursue our future dreams. Next slide. Unhealthy dietary behavior. For us, to become like other celebrities. For example, in socialite medias, we see some certain figures, we see some certain body structures. So when we eat some food, like for example, bulimia, we tend to eat some food, then vomit, then to maintain that figure and that body shape language and body image. To maintain the figure, I've also talked about it. Next slide. Physical fighting and vandalism. These are the risk behavior that we do. Why do we fight and vandalize properties? Political affiliation. For example, in this current, we are in campaign season. So if political party disagree in a way, and I'm in a certain political party, I'll have to tend to vandalize some properties. For example, in 2007, we did so. Being rebellion. For example, in schools, there are rules and regulations that are given. So we tend to be rebellious to the rules and regulations. That's why we fight and we vandalize properties. Relationship-wise, if I'm being cheated on or I'm being heartbroken, I tend to fight this other partner in order to maintain my interest as an adolescent. For debts, we fight because somebody owes me some cash or own me something. That's why we tend to fight. To prove who is strong, that is true, to see how well I'm strong. Then alcohol and substance abuse make us fight. Peer pressure, for it's true. Like, for example, if I was beaten yesterday, a friend comes and tell me, you just uliachilia huyo jamaa akupige. So it is pressure from the other side. So I tend to go and fight the other person in order to get the strength, to prove that I'm stronger. So it's peer pressure. Next. These are the challenges and the risk behaviors captured in one. Next. Thank you. And before I thank you, this is a picture that shows how we do it. Nipe Viagra na P2 na number wa fundi wa kitanda. So it's, you know what it will end up with. Thank you.
Thank you so much, Hilda. Hilda is a peer working at Rafiki, which is an adolescent center in Moi Teaching and Referral Hospital, and she does a very good job there with counseling the youth. And we can clearly see why we need peers to do this kind of thing, why peer support is a very integral part of managing adolescents, because they can understand each other, their language, they can relate. So extremely important. It's also interesting to see how peer influence is very much a part of how adolescents think, the decisions they make, and what they do. So that was extremely illuminating, Hilda. We'll have questions at the end again. I will hand this back over to Dr. Karingo to guide us through the rest of the session. But thank you to all the presenters.
Thank you very much. Thank you very much for those sessions and for that, for those discussions on matters on youth and very interesting conversations here. Thank you so much, Hilda. I'll hand it over to our next chair, Dr. Bukusi, to take us through the opportunities for collaboration between stakeholders in adolescent health. Dr. Bukusi Karibu, he has done a lot of work in mental health, in HIV, and running programs. And you can take us through introduce yourself more and take us through the next session. Thank you.
Good evening, ladies and gentlemen, and thank you again. Thank you again for those particular presentations, Dr. Yaguga. You've done a great job, and Agnes, you're also well. It's very pleasant for you to have this to ensure that we have these particular presentations. I mean, they've been really interesting presentations. I was really looking forward to a very great extent to listening to Ministry of Education initiatives around adolescent mental health. Unfortunately, they seem not to have been here today. Possibly we may get in touch with them a bit later. My job is to work with the panel to look at different opportunities for collaboration between stakeholders in adolescent health. And this is extremely important, as have been appreciated from the different presentations. We have, let's see, Professor Ndwati, bringing a wealth of experience, University of Nairobi, pediatrics. Dr. Celestine Mugambi, National AIDS Control Council. There's so much going on within the context of human behavior with regard to HIV, and clearly a significant cohort in that particular population is adolescents. Nakada coming in with Adrian, again, presenting some excellent thoughts around the issues of adolescents and youth within the context of appreciation of drug abuse, substance abuse, what can and cannot be done in different ways, looking at the different data that they have at different levels. Dr. Omondi, again, looking at these really very useful and hands-on findings from clinics, from actually seeing the clients as they are presented, looking at different interventions. Dr. Njuguna presenting these the different thoughts and policies, protocols which we are looking around to see how to address adolescent mental health, which is to many people's minds is fairly key within the greater context of mental health, of adolescent health anyway. Then, of course, now we've had this excellent presentation from Hilda, who's a peer mentor working with the Rafiki program at MTRH, if I'm not wrong. Dr. Kibuge, you can correct me there. And there are a lot of very interesting thoughts and ideas around here. We're talking about opportunities for collaboration between stakeholders in adolescence. There are a couple of areas which I was hoping to be able to hear from. Ministry of Youth, Gender, Sports, for example, an area where we could, again, get input on what is available, what is in place, what can be tapped into with regard to support for support of our adolescents. And of course, perhaps Ministry of Internal Security. We know that our prison population, a significant proportion of it is falls within this particular age group that we're dealing with. And a fair amount of why they're perhaps in those particular institutions, including hostels, is as a result of experiences that they have gone through in childhood and have now manifested within the context of adolescence and young adulthood. So as we think about this, all these particular different players, I'm curious about perhaps maybe what you think are your thoughts around what kind of collaborations we might be able to develop. And I perhaps put across a couple of pointers as I will possibly, I will be putting this to each of our presenters, and I hope that you guys are all there. Professor Ndwati, you took us through an excellent presentation on the neuroscience, on this neuroscience behind risk-taking behavior. In fact, at some point, we used to say that the maturation of the brain starts at the back. That's where you learn to see things. And as it gets mature, you're 10, 11, 12, 13, suddenly you start seeing the differences between boys and girls around you. That's when we start noticing who is who. This is actually a boy, this is actually a girl. As we head into our mid-teenage, 14, 15, 16, suddenly the middle parts of our brains, the parietal and temporal areas, and the areas which deal with emotions come through, and suddenly your emotions are ruling you left and right without any breaks, as somebody put it. And then we have the executive functioning of the frontal lobe. So we start the maturation from the back coming through the front. What do you think perhaps are the implications of this on adolescent health? And perhaps how we could include this within the context of our, one, parenting, and two, schooling, the two major socialization environments that we actually work within. Professor Ndwati, please.
Thank you very much, Dr. Bukusi. That's a really good question. I think the number one thing is that we need parenting lessons, and the parenting lessons should include knowledge and skills on how children develop. I was asked to just talk about the adolescent, but you know, bonding, which sort of starts in infancy, is one of the most powerful tools for manipulating behavior. A child who's well bonded with a parent is less likely to be a risk taker. So I think the training, parenting skills on how to develop healthy relationships with their children and to create healthy environment is key. And this is how this information can be utilized. The second is that this same thing should be included in training of teachers. And in training of teachers, I think there should be some depth in the training on the child psychology, adolescent psychology, issues of how to manage discipline and to bring out how to motivate their students and to bring out the best and to create a safe environment. I think the third target of this information is the pre-teens. You know, you tend to, you know, as it's getting into this adolescent period, they need to know the knowledge of self and knowledge of what to expect is arming the child for the space they are going to face. So a little girl should not just happenly just discover that there are periods on the day she has her first period. There should have been some knowledge around that. and even skills on how to manage their periods, the use of sanitary towels, how to dispose of them. And she should have some in store for the day that it happens. Knowledge that can also lead to pregnancy. They're not, for all adolescents, the understanding that you will swing into this mid-adolescence where everything, you feel invincible. Your brain just pushes you to take risks. And to have the knowledge, at least to have had, and to have the knowledge that sometimes your brain is going to be telling you the wrong thing, and that you need to consult, you need to listen to others. I've for many years taught adolescents. We've had a transition program in our local church, and had even my own children go through it and have them give feedback. And they say that you hear it about them telling you around mid-adolescence that, you know, that thing you used to talk about, it's true. It really hits. And then when they've transitioned out, they say, wow, I'm glad I knew, because it made me think twice about some of the issues my peers were pressuring me. So I think I really think that that knowledge of human development, especially that cognitive development, is needed both by the parents, the teachers, and the young people themselves. So that's how I think we should use that information. I think one other thing we didn't talk about, and it relates to the cities, is that in the city, many people live in a one room. One room is the house. So from very early, children are exposed to sexual activity. You know, the parents sleep on the bed, the children sleep under the bed. So there's a disinhibition towards sexual activity. This is very different from the traditional house where Muze had his own hut, the wife was in her own house with the children. This is a phenomena that of urban living. And I think this is also contributing to this very sexualization of our young people very, very early. And I think the other partner in this discussion should be the Ministry of Housing. I think we need laws that regulate the kind of space a family with children can live, and versus a family of, you know, individuals who don't have kids, as part of trying to protect these young people. Thank you.
Thank you very much, Prof. That's an excellent answer. And yes, we are going to look at the different aspects of parenting, and I'll be asking some of the other panelists as well what their thoughts are around that. My second question, which we'll be touching on some of these things. And she has presented an excellent overview of what their thoughts are around sexual risk, taking and mitigation strategies for adolescents. And one of the things that I'm very happy with NAC about is their program with regard to HIV prevention, HIV interventions, HIV education, you know, in the whole spectrum of the Kenyan space, so to speak. And it has been, I think it has been incredibly successful and continues to be so. As you know, as first of all, NAC continues to have that particular mandate in the country. Now, within the context of the NAC mandate, now we also have a particular arm which is talking about mental health. When we're talking about I mean, yeah, these are the new indicators that NAC is looking at. And it's helping develop awareness within the context of the workplace around issues of mental health, around issues of various forms of risk in terms of behavior around the same. And considering its reach, do you think, Dr. that there is an opportunity here to perhaps further strengthen this particular intervention in terms of raising awareness and the concerns around mental health within the context of these new indicators that NAC is pushing? Dr. Mugambi.
Thank you, Dr. Bukusi. Very interesting question. I think I had said when we're talking about multi-sector collaboration, we have to look at each institutional or sector strength or comparative advantage and leverage on that. Now, by virtue of being at the NAC, our legal notice is very clear. It is multi-sector coordination. So we're able to pull everybody who is in the business of HIV prevention. And we do approach it from a preventive and a promotive aspect. In terms of integration of mental health and even other emerging issues around non-communicable diseases, that we have done. There's opportunity and we continue to do so through our various partnerships. And just to give an example of how we are doing it, because we have this slogan, HIV is everybody's business. And so we sat back and thought, how do we make them everybody care or respond towards the HIV epidemic? So, you know, every government agency signs performance contracting, and you have to come up with your own set of indicators. And so HIV over the last 4 or 5 years was one of the performance contract indicators that each government institution had to report on. When we started, it was just about reporting on HIV, numbers reached, numbers tested at the workplace, because we have a very big workforce in the public sector. And if you multiply by 4 or 5, that's a lot of people who can potentially reach other parents and their children and like. So at the initial concept was around just HIV, but recently, and I think the ministry has been part of this with the NCD team, we have actually integrated aspects of mental health and non-communicable disease, simply because of the integration that we are seeing, or the dissection between HIV and non-communicable diseases, and mental health being one of them. If you look at the data around, for example, diabetes, hypertension, the number of people living with HIV actually have got a higher incidence and higher rate of non-communicable diseases. But also what we have seen around mental health for adolescents and young people, even for the older folk alike, determines your risk-taking behavior, determines whether you access services or not, determines whether you stay on those services and actually benefit from them. And every time we have engaged young people, now drilling down to today's subject matter, mental health has been something that has come up repeatedly. They say we have got anxiety, we have got depression, we are unsure about ourselves, we've got low self-esteem. All those ones really have been contributing towards the epidemic that we have been seeing. So we sit in that comparative advantage where we're able to pull everybody. And so using that platform, then mental health now is something which the public sector is going to start to talk about. And the work also is going to be extending towards the private sector and really transforming the workplaces into wellness centers. So I think we need to think about not just HIV, but indeed the whole health response. Who can do for us our job or help us with our job by virtue of where they sit at no or minimal cost to them, and what support do we need? So we really have to move out of our clinics, out of our boardrooms, out of Afya House. We have to get there and into the community. I think also engagement of the community around these issues is key, and there's always opportunity for that. And the community is wide. It's just not networks of young people or people living with HIV. The community is the parents, the community is the church, the community also is those who are in this webinar. So each of us have got a space. It's just a matter of mutual accountability and how to ensure that all of us are working towards a specific direction. So that's what I would say. Thank you.
Thank you. Thank you. And I guess one of the things that we do appreciate, even at the workspace, in the workplace, many of the difficulties that contribute to some of this depression, anxiety among workers is the state of health of their children, including their mental health and other adolescent issues. Sometimes you get to a meeting and you start talking about your adolescent, and then everybody starts talking about the adolescent and the problems that they have. And I guess this is the kind of place that I'm thinking about opportunities. Thank you very much, Dr. Now, Adrian Jenga Nakada, again, excellent presentation, and I was really excited to appreciate the materials that you're marketing, so to speak, in terms of addressing issues of risk behavior as far as substance abuse is concerned. And you have done some work with various schools in various areas. I guess my thoughts are along these lines. How are we managing to disseminate this information so that perhaps relevant organizations may actually be able to appreciate that, one, this is going on, and two, obtain some of those particular materials to incorporate them within programs within their churches, within schools, or within social functioning areas? Thank you. Adrian.
Thank you, Dr. Bukusi, for the question. Indeed, as you pointed out, the last 2 years has given us an opportunity to re-strategize on what we need to do to address the emerging problem of substance use in our country. And this is still new work. The guidelines that I alluded to that we developed with the Ministry of Education and other actors in the education sector were launched just last year. Actually, this year in the month of June, when we were commemorating the International Day Against Drug Abuse and Illicit Trafficking. So for this particular year, financial year, what we are doing is that we are collaborating with schools across the country to disseminate these guidelines. Again, because of the challenges that we have with COVID, it's much easier for us to engage teachers within the 9 administrative regions that we are working in across the country. But then additionally, because we acknowledge we're not the only ones working in that space, we are also engaging civil society actors and other non-state actors to equip their capacity to be able to understand what are the evidence-based programs that we are pitching for now going forward, and what are we not classifying as evidence-based. Some of the things that we've had to do is have a discussion with the Ministry of Education with regards to vetting organizations that are working in schools, and to ensure that the kind of programs that they are also implementing are hinged on evidence and some research that we can be able to cross-check and confirm. So we work through different actors, both at state level and non-state level, and perhaps the other stakeholder that also has to be part of this exercise are the county governments. A bit of the functions were devolved to them, and they have a very serious and cardinal role in ensuring that, for example, for a case, the aspects of alcohol control and aspects of drug control are addressed within their jurisdiction. There's something that, for example, Dr. Mugambi pointed out about the influx of the wines and spirits. As an authority now, that function has since been devolved to county governments. So when we get such reports, we bring it to their attention as a county government of Nairobi, that these are serious concerns that we are having with regards to access, to the number of outlets available within your jurisdiction, because that also has an impact on access. So I think broadly, the strategy that we've adapted with regards to dissemination is stakeholder collaboration. And no wonder we were excited about this opportunity to participate in this forum organized by KNH-UoN to have a discussion about what other interventions are working for adolescents, and how can we collaborate to ensure that the same is successful and replicated across the country.
Thank you very much for that response. And perhaps a bit of a follow-up. So should any institution around wish to use some of these materials and use your expertise, what would they do? They come to you, they write to you, how do they set up any collaboration that they might wish to put in place?
Well, to begin with, for public sector institutions, just like with NAC, we advocated for the reinstatement of an indicator on performance contracting, which is the prevention of alcohol and drug abuse at the workplace. Because during this COVID period, we noticed that there was also an increase in the use of substances by public servants. We have close to 800, slightly above 800,000 public servants across the country. And during that time, we were able to undertake a survey on the status of substance use in the public sector. And we were amazed to see that the numbers that we got were actually above what we are seeing at national level in terms of prevalence. So for public sector institutions, we already have a framework for engagement, including what you alluded to earlier, that you could be in a meeting with colleagues, but your primary concern is how your son or daughter is challenged with regards to a risky behavior that they're experiencing, including now substance use. So we already have a framework for engagement with public sector institutions. But for non-state actors, they can get in touch with us, not just in Nairobi. We have offices in Kisumu, in Kakamega, in Garissa, in Mombasa, in Embu, and in Eldoret, and lastly in Nakuru. So they can get in touch with our offices. That information is available on our website, and they are free to reach to us through email, or even just walking into offices and asking for collaboration. We are more than happy to partner with anyone who's implementing programs to reach the different communities that we are working with.
Thank you very much. Thank you very much. Excellent information there, Adrian. Therefore, those of us who are looking for some collaborations, these are the stakeholders who are in place we can work with. I'm coming now to Dr. Josephine Omondi. Josephine Omondi has been a colleague of mine. Indeed, we've had a lot of discussions around this issue of adolescent health. And very often our issue boils down to parents. You heard emphasizing it over and over again. And this is a question that I'd like to put across to her. And even as we're talking about parents, one of the things that did happen over a period of working together at the Kenyatta National Hospital Youth Center is that we appreciated that there were different areas which caused a lot of challenge for very many of the young people who were referred there. That particular unit deals with young people of the age, between the ages of 12 and 25, 24, something to that effect. And one of the issues was sleep. A second issue was ranking in schools, causing a lot of problems. And then a third issue was tuitions. And that we actually did manage to write to some of the facilities, actually the Cabinet Secretary of Education, around these particular issues. Now, as to whether it was as a result of what we wrote, but we wrote a paper which was talking about kids need to sleep. This ranking of schools is stressing our children, adolescent health. This perpetual living in tuitions is not particularly useful. Children need to be able to learn to do other things as well in the community life. And there were various communications which came from the ministry around these particular other things. But what I want to emphasize again now, and in asking Dr. Omondi, when we talk about parents, we're talking about parents and the different forms of mental illness that eventually end up coming to us, so to speak, the clinicians. What is it that you really expect of the parents? That is one. And two, how is it that you would like to collaborate with the spaces where these young adults who are referred for clinical care, whether it's the Ministry of Education, whether it's the Bostals, whether it's community activities, what would you like to see taking place in terms of strengthening that collaboration and hopefully other health facilities?
Okay, thanks so much, Dr. Bukusi. Now, parents play a big role in a child's life. And remember, Professor Ndwati also mentioned a little bit on attachment. Now, the first person for the child to attach to is a parent, hopefully if the parent survives. Now, this attachment process provides the child with confidence, building trust, ability to regulate themselves, the first part of socialization, and also mentalization, ability to read the other person's mind. Now, if the parents are not available psychologically, this then gets affected. So it's important to emphasize that the parents must be available throughout. Number two, the family and with both parents, that's the first place where the child learns, is the first educator. The first educator in terms of controls, in terms of discipline, in terms of self-awareness, in terms of organization and other things. So parents are the ones who should regulate, and they are actually, if they are good enough parents, they're the ones that provide the child with, build the confidence so that they can continue maneuvering their life in an organized manner. But there are many families that don't have the parents. So there is somebody else who comes in the form of a parent, but is more of a quasi-parent than a true parent. So then things start going wrong. So I still emphasize that parents are the role models. Parents are the key educators. They are the priests, they are the teachers, they are the nannies and everything for the child to be able to emulate. Now, going further to the community, I don't know about the second question, but a way forward, it would be good if we adapt what we call family-centered and community-centered approach towards helping these adolescents. Now, HIV care has been very, very well resourced right from the beginning up to today. And the programs have come out so well. And I think there are many ailments that we have copied HIV program so that we can also perfect the treatment. So the same way in the adolescent healthcare, I think we need to adapt the HIV care so that they have people whom they can talk to, whom they can vent their issues with, and who can give them the right information at a family level, at the family level, then at the community level. And here I'm talking about school-based programs. Now, within the school-based programs, there is an interaction between the teachers and the healthcare providers. There are these people whom you call children's officers and community-based health workers. These people have a lot of information and they are trusted in the community. And I think they can be very, very useful being put in this program so that they can help the community. Because as we speak now, we are speaking at the upper pillar of the society, but what about at the lowest pillar in the village, in the community? I think we can go beyond this so that we use them. And other programs have used them before, especially the NGO sector. They've used these people and they're really, really very, very useful. I hope I've answered that. Thank you.
Thank you very much, Dr. Very useful. I know that even, for example, right now, I think senior citizen care, geriatrics, they're also developing a program which is looking at utilizing community health workers to sensitize on issues around geriatrics, older person care and respect for the same. And they want to roll it out. So, well, I would agree with you in terms of using some of the structures that have worked in the past, and we'll ask Dr. Juguna shortly around that. The other area which I'm intrigued in is that you run a youth center at Kenyatta National Hospital with a wide array of pathologies. And this is, I think, was alluded to in one of the other presentations, that sometimes the parents themselves are the source of the pathology that the patients, that the young people actually come in with. But I'm curious about possible collaborations with Moi Teaching Hospital, because they seem to have the same. Is that correct, Dr. Jaguga? Dr. Jaguga, are you there?
Yes, I'm here. I'm here, Dr. Bukusi.
Yes, I was
just
asking
the question. Yes.
Yes, I mean, I was just asking about, you have a youth program, youth health program in MTRH?
Absolutely, absolutely. We do have an adolescent health center of excellence, actually, that focuses largely on HIV, but also other aspects like mental health as well.
Okay, so it might be useful just to exchange, have some understandings of what are the different kinds of issues that arise and your different strategies in addressing them, and perhaps build, especially at that particular level of the hospital. Remember, our adolescent care, healthcare is well, it starts within the family, obviously into the community, but when things get really thick, we head out into
I think we lost Dr. Bukusi, but Dr. Edith Apondi, you're here, and I think you're best placed to talk about the work that's done at Rafiki.
Very useful indeed, yes. Let's do that.
Karibu, Dr. Apondi.
Thank you, everyone. So at MTRH, we have an adolescent clinic called the Rafiki Center for Excellence in Adolescent Health, where we see adolescents, we target adolescents 10 to 19 years. And then once they're in the program, we use the 20 to 24 year period as a transition period. We have about 800 adolescents living with HIV. And of course, their care is basically the adolescent package of care related to HIV. But we do also offer HIV prevention services, including condoms and PrEP, where most of our clients are adolescents in discordant relationships with those ones who are our clients, and then also adolescents from the LGBTQ community. And we do also have adolescents who are in the MCH. So as much as they receive services from the MCH, they do come for PrEP from the Rafiki Center. And then we do offer a lot of sexual and reproductive health services, including health education, promotion of family planning and contraceptives. And we also do offer STI screening and treatment. And these services have been waived by the hospital. So because the cost implications of accessing care among adolescents. And then of course, we do also offer mental health screening and treatment where Dr. Jaguga, and we also do have a psychological counselor, a diploma level psychological counselor who helps us with the counseling. And then if they are psychiatric, we do get support from our psychiatry department. We collaborate between MTRH and Moi University. And also we do have partners from North America who are led by the Indiana University. And their support is largely training, technical support, and a lot of financial support as well. Of course, some of the challenges we experience include things like having the center be a one-stop shop. For instance, we've not been able to offer MCH services, largely because it is an outpatient setting, and we are a bit far from the main hospital, and we fear having adolescents who are in labor coming there. And so we prefer to retain them in the MCH where it's near, where they can be attended to in case of emergencies. And then we also do have challenges like it's sometimes difficult to describe or to define adolescent health, because we do have adolescents with other chronic diseases like diabetes, like cancer, like renal diseases, and they are all over the hospital. And so sometimes it's a bit challenging to get the other centers to be able to understand who to refer to the clinic. And that's why, as Dr. Jaguga said, it has been easier for us to access the adolescents living with HIV than the adolescents with other chronic diseases who we also are targeting with the services that we offer at Rafiki Clinic. We do also serve street youth, where we offer them HIV services, HIV prevention services, mental health. And once in a while, we do get food support. We do also get repatriation back to homes for those who are willing, education for them and stuff like that. And we also do have quite a bit of LGBTQ targeted services. Most of these other communities, we are able to serve them based on grants. We do apply for grants to help us in a lot of non-routine hospital services. So I may stop there in case there are, and wait for any other specific questions. Thank you.
Thank you. Thank you very much, Dr. Apondi. And even just listening to your explanation and just description of the services that you're providing, it again takes our mind back to the positioning of youth health services. This has been a bit of a challenge, even within the context of youth health in the first place. Where do you actually provide it? The Rafiki Clinic seems to have been started around issues of HIV, which was not which is a good thing, because that is a captive audience. I know they have a bit of the same in Kisumu, in Nakuru, and a couple of other areas, including Kenyatta National Hospital, was started around reproductive health. And yet we do know that there are very many other issues that come through for adolescents within the context of our health services. As Dr. Mondi will tell you, while it was started in the context of reproductive health, 90% of the patients seem to come through with much more of mental health issues. But those are debates which need to be taken up at policy level. Now that I talk about policy, Dr. Njuguna, if you're still on, from the mental health task force findings, were there any thoughts from the communities that we went through and interacted with about how best to deal with our youth health issues, substance abuse, pre-teenage pregnancy, and all these kind of things that happen within, and these increasing amounts of suicidal attempts, self-cutting, which used to be considered something which was foreign to our environment, but is now quite common. Any thoughts that you might be able to be able to share with us? And then secondly, dealing with policy. So how do we disaggregate, segregate, if at all, youth health services within the context of our healthcare service provision? Thank you.
So thank you, Dr. Bukusi. Those two questions, what the Mental Health Task Force found from the Kenyans, and also about how do we structure the youth friendly services in terms of policy. So basically what we found when we went to the Kenyans during the process of hearing from the people was, especially from the young people themselves. We heard from the young people themselves, we heard from the older persons who mainly could be their parents. And what was coming out was the issues of the society in terms of looking at the various risk factors and the determinants within our society, and especially what is affecting the young people. And in the task force report, we have a whole paper. It's even a part of the annex of what was presented by the young people. Mainly the adolescents were there, but also what we consider as the youth going all the way to the age of 35. And you'll be surprised, some issues around social determinants also came very strongly in terms of the environment the young people are growing in. The issues of, especially now when you move out of the adolescent, is the issues of poverty within the socioeconomic status within our communities. Whether they are the adolescent or the young people, maybe the young people now will be talking about jobs, but the adolescents are growing in very difficult socioeconomic environments. And so this exposes them to a lot of these risk factors, substance use, issues about teenage pregnancy, the issues of HIV/AIDS. You remember that chart we saw presented by Professor Duarte, where we'd see, it's a whole complex thing, where socioeconomic status lead to risk behavior, risk exposures to HIV and substance use. And it's a vicious cycle. That came out very strongly. Then also what came out from the young people was where do they seek for services? The issue is not even more about the awareness. The level of awareness is quite high. Most of our young people are quite well informed. And what came out is the access to services, whether can they afford the services, are the services available, are the services acceptable in the way they are provided, are they really centered around
friendly to the young people. So those were two issues. And now let me come to what would be the policy response around this. What we have thought, especially at the policy level, addressing the issue of mental health, is starting to address it from a perspective of a whole societal approach, a whole government approach. And where and that's why the documents we have come up with, we in terms of policy and document, I can tell you we have enough. What now we need to do is to make sure they are well disseminated and well programmed within the various sectors, within whether it's education, whether it's within the security sectors, because this is what's now going to change things, and then put investment around those things. So that's also bring an element of more awareness and advocacy, so that people can say, this is what we have identified from the people. This is the policy response. How do we move policy in terms of to the practice, to implementation and seeing impacts? So moving from policy to impact is the stage we are in. And this now brings you a question about how do we program youth-friendly services? How do we program, or how do we structure youth-friendly services? And it's a quite a difficult question, because as you see, services touching on the young people cut across, they'll cut across the various, the multidisciplinary teams and the various sectors. So the key thing is mainstreaming as much as possible in all the sectors, and trying to build the necessary capacity within those other sectors, whether it's within the reproductive health services, whether it's within the other services. Can they have people who are competent enough to address issues about young children? But then also, what we have also found is the use of technology could be a way in which you can access to the young people. So the aspect of telemedicine may be one of the approaches we may start using, trying to access the young people. Then when it comes to the actual programs, before you provide services, let's push services towards the community. We have those spaces within the community. Also, what came out strongly among the young people is getting the young people within the policy, within the service, so that the young people are getting services from the young people. They are having input in terms of the way the policies and the plans are being implemented. So empowering the young people to be the drivers of their programs, their services, and also policies affecting them. So it's a work ongoing, because I think we have been so much behind around this, and the young people account for 2/3 of our population. And I think the shift now in terms of policy and programming has to go towards to be focused on the young people. Thank you, Dr. Bukusi.
Thank you very much, Dr. Njuguna. I know time is not on our side. I hope Dr. Karingo, you can allow just one quick more response. We still have Hilda to give us a quick response, if you may, Hilda. This is a question that I'm going to put across to you. You've heard quite a number of the presenters, you as a peer mentor for the adolescents, and you've talked about the different risk factors and different issues that young people are actually very interested in. Let me ask you a question. What would you, now as a representative of the young people, the peers that you interact with, what 3 quick things, if you can think of them, what would you want parents to be aware of, and what would you like them to do? Hilda, are you still there? Hello, Hilda. Have we lost her? Okay, perhaps we have lost her. Yeah, sorry.
I think we might not have her. Trying to look. No, Hilda, she's there. Hilda, are you able to hear us? I'm saying she's on mute, but
Okay.
Okay.
Well, thank you again, everybody. Thank you again, the presenters. You've done a wonderful job, and even answering those questions. And I think even as those answers were coming through, there were more ideas about how it is that we can go forward from here. an issue of sometimes the coordination of this particular activity of youth health is it still remains a bit of a challenge because of so many parties really involved in this, but at least there's thinking in the different sectors, in the different spheres, and the development of the same. The hope is that we'll be able to get some umbrella that will be able to drive us forward. So once again, thank you very much. I'll hand this back to Dr. Karengo, please, as we end to a finish. Thank you very much.
Thank you very much for that, Dr. Bukusi. We want to really appreciate the conversations that we've had this afternoon. We want to thank our participants for staying with us till now and for contributing to this very important conversation about the adolescent health. A lot of challenges we have seen, but with collaboration, we're able to deal with some of these and even move forward in matters adolescent health. So without much ado, we'd like to really appreciate everyone. We appreciate our presenters for giving us those informative sessions, and just want to really thank you and even welcome you back again to just stay with us even for the coming sessions for these insights. Thanks Prof. Nduwati for that insightful session, Mr. Adrian Jenga, Dr. Josephine Omondi, Dr. Mugambi on behalf of Dr. Masha, we have Dr. Simon Juguna, Hilda. We really want to thank you, and also for our chairs, Dr. Bukusi, Dr. Jagunga. We really want to appreciate you. So as we come to an end, we'd like to invite you for our session in the evening. We're going to be talking about this trial, the randomized trial of single-dose HPV vaccination efficacy among young women. It will be starting at 7 p.m. and we are going to be having more science, talking more science in the evening and matters used. So we really welcome you for that. For those asking about the presentations, we have the sessions, they'll be uploaded in our website. For any specific session for easier follow-up, you can email us at knhresearch@gmail.com and you'll see how best to disseminate this information. With that, let's bring this to an end. Have a lovely evening and goodbye.
Thank you, bye.
Thank you. Go ahead, Reed.